Now, what are CCDDs? Congenital cranial disinnervation disorders. Now, the name by itself suggests that these are congenital, these are cranial, and there is a disinnervation, and it is a disorder. Now, this term was coined by in 2002. It's 20 years now, and this term has stuck, and lot of conditions have been added, lot of things have been learned through genetics and through imaging. So those two aspects have really added to the wealth of information, and new entities have come in like third nerve palsy, fourth nerve palsy, and so on. So we'll be just we'll just talk about those conditions in a brief way because time is very limited. Now, what are CCDDs? These are abnormal development of cranial nerve nuclei and or their axonal connections. That means either the nucleus or the peripheral nerve is not developing properly. Some of these also have maldevelopment, which is prenuclear or supranuclear. So that you should also keep in mind that you can have conditions like AGPPS, where the problem is in the midbrain and pons development. So that can also happen along with this. So these could have broader implications for neurological development. These are mostly heritable, but can also be sporadic because of mutations. So there is, first thing is there is a primary disinnervation. That means there is lack of innervation. Either the nucleus has not formed, or it is hypoplastic, or the nerve has not formed, or it is hypoplastic. So that is the basic substrate on which it is going to develop further. So secondary thing is that is disinnervation. That means something else comes and supplies that part of the muscle. Like if you look at the embryology, the third nerve is going to supply the entire mesoderm around the globe, which is going to form the extraocular muscles. The sixth and fourth nerves are later invaders. They come later and claim their territory. Now, if there is some problem in this division of their territories, then there will be a problem. So all this thing is very well guided at biochemical level. So it is very complex matter and very well guided and done by the body. Now, if there is any failure anywhere, there is going to be a problem. So the hallmark feature is that there is a variable component of paresis and restriction. So this becomes a complex business because you have a paresis and you also have a restriction. Now, this component may change. You may have conditions which are mostly restrictive, and you may have conditions which are mostly paretic. So you will have wide spectrum of presentation from almost total restriction to some paresis, and along with this also comes some kind of aberrant innervation. Restriction, paresis, and something coming elsewhere. So it makes it very complex. Like you all know about Duane's retraction syndrome. At times it can be mind-boggling, and you wonder what you are dealing with. But then you know that ultimately it is DRS. So broadly, we can have them at two levels, either at the level of the midbrain and the level of the pons, because that is the basic brain, the medulla, the pons, and the midbrain. Rest of the brain has come up later. It is like an add-on. It's like a sweet dish, which we are having. Most lower animals don't have this kind of cerebral cortex. Six-layered cortex is a luxury. Most non-mammals and lower animals will have maximum three-layered cortex. So nature gave us 6 layers, and making it all the more complex for all of us. So at the level of the midbrain, we have what we call as congenital fibrosis of extraocular muscles, which is again a very important condition, rare, but once you see it, you know that this can be quite mind-boggling. Then you have congenital MED, which is monocular elevation deficiency. You have congenital Browns, which is a late visitor to this group, because we knew about Brown since 1950 when it was described by Harold Ridley Browns, but a lot of water has flowed since then. Then you have a small group of congenital third and fourth cranial nerve palsies. You, I think, already know that the third nerve palsies, which are congenital, can also have aberrant innervation. But we never looked at them at CCDDs, but now we know that a good number of these, on neuroimaging also, they show a lot of other evidence which shows that these are CCDDs. And fourth nerve palsy, you know, is the commonest congenital cranial nerve palsy as far as we are concerned as an ophthalmologist. And there is very often hypoplasia of the fourth nerve nucleus and the nerve and the muscle also. A good number of about 50% of superior oblique palsy will have superior oblique hypoplasia. So there is a direct relationship between the nerve and the muscle. If there is a problem with the nerve, muscle is going to be affected. And then, of course, congenital ptosis, you all know. especially if it is bilateral. Then at the level of pons, you have Marcus gun, jaw winking phenomena. You have DRS, which is the commonly CCDD, as you all know. You have synergistic divergence, which could be with DRS. And then you have BSAS and ABDS. Now, what are these BSAS and ABDS? Bosley-Sally Elorani syndrome, which is seen in Gulf countries. And this is like bilateral DRS with a lot of middle ear problems. And then you have ABDS, absorption brainstem dysgenesis syndrome. This is seen in South America. So both these conditions are SAL4 mutations, SAL1 mutations, which can be shared with DRS. So there is sort of a cross connect with DRS, synergistic divergence, BSAS and ABDS. Then you have SGPPS. What is this? Horizontal gaze palsy with progressive scoliosis. There is a scoliosis which may not be apparent in a child which is young. By 2 to 3 years or by 7, 8 years it will come. It is autosomal recessive, so a good number will not be affected, or parents may not be affected, but children may be affected. And you will have eyes which look perfect. In fact, many of these cases get missed because I know of cases which have gone to All India Institute, have not been diagnosed, gone to orthopedics for scoliosis, and they have not been diagnosed. So it can happen. All of us can make mistakes. So you have HGPPS, we will show you some cases. Then you have Mobius and Kalman. I am sure you must have heard about this. Mobius was not an ophthalmologist, he was a neurologist at Leipzig who classified these all cranial nerve pulses into different groups. And he placed some of these 6th and 7th nerve pulses together, which now we call as Mobius syndrome. Then you also have congenital facial nerve palsies and crocodile tears. Crocodile tears you all know, I suppose. Crocodiles are supposed to cry when they eat their prey. It is a myth. Nobody knows they actually cry. So crocodile tears come from that myth that when you are salivating, you are also having tears. So this is kind of disinnervation. Now, tubulins are important. These tubulin proteins are very important for neuronal development. Now, if there is a problem with these tubulin proteins, then you can get into a lot of problems with the CNS development. So, two types of CFUM, which is TUB3 and TUB2B, they can give rise to a lot of CNS involvement also with these CCDDs. So, you may have CCDDs, you may have CNS involvement without CCDDs because of this TUB2 and TUB3, or you can also have CCDD with a lot of CNS involvement. So it needs to be looked beyond eyes. You also have to examine them systemically and see what else they could be having. As I was talking, with TUB3 and TUB2B, you can have malformations of the cortical development, dysgenesis of the corpus callosum, corticospinal tracts, basal ganglia, and hyperplasia of the oculomotor nerves, microcephaly, microgyria, polymicrogyria, vocal cord paralysis. So all these things can happen, and of course they can have intellectual disability. So you need to have a broader and global evaluation in these cases. Now imaging has done a very good, has been a great help. Like we know 1/3 of the third nerve palsies may show hypoplasia. About up to 70% of fourth nerve palsies can show CN4 hypoplasia or aplasia. And in DRS, and you have cranial nerve 6 absence or hypoplasia in type 1, it could be absent. In type 2, it is present, and in type 3, it could be variably present. So in DRS also, imaging is going to help you. Mobius syndrome, as we were talking, 6th and 7th nerve, you can have CN6 and 7 aplasia or hypoplasia, and it has a lot of systemic involvement. Mobius, we don't have time to talk about this in detail. CFM3 shows cranial nerve 3rd, hypoplasia, and synergistic divergence and synergistic convergence can mostly show CN6 hypoplasia because they are happening at the level of the pons. So we talk about CFMs. These are, as I said, these are primarily fibrotic situations, restrictive strabismus, because there has been no innovation, so they have gone in for restriction. So the main thing is that there is paresis followed by restriction, but paresis remains the primary event. Now there are at least 8 genetically identified syndromes which we already know. Tuchel syndrome has not been identified, so more will be added to it as more and more genetics progresses, so probably we'll add more to it. Now inheritance is autosomal dominant for most, and autosomal recessive for CFM2 and 2KL syndrome, which we don't know till now. Rest are autosomal dominant. Now, phenotypes can be very broad. There are a lot of variability in presentation, so they cannot be a typical presentation because depending upon the restriction, depending upon the horizontal movements and the strabismus, lot of variability can be there. But what is most consistent is that there is by and large ptosis, which is also not always there. You can also have a lid retraction, but they have a down gaze. Eyes are fixed in down gaze, and there could be an A pattern, convergence in up gaze and divergence in down gaze, what we call as A pattern. So, you have ptosis, you have eyes fixed in down gaze, Bell's is poor, and they will usually have a family history. Chin up position because eyes are fixed in down. I think we can extend by 5-10 minutes. Yes. Okay, thank you. So, this is one family. You can see 3 generations, the grandfather, the mother and 2 children. They all have similar mirror image picture. All of them have CFM1, eyes are fixed in down gaze, all of them, and they are not able to elevate the eyes. If you look at this girl, there is an exo also, there is a variable limitation of horizontal movement, there is ptosis, trying to look up, there is lid retraction. They have lot of astigmatism. Important to keep in mind that they can have refractive errors and large amount of astigmatism. So, you should always refract them, do their refraction, and they will have amblyopia, very poor binocularity because they have never had an opportunity to fuse. So, amblyopia and binocularity will be very important to look into. This is showing you have an extortion in this child, fundus extortion, as you can see. Another girl in this group only has intorsion. So, why one has extortion, other has intorsion, 2 sisters, will not be able to go into this at this moment. This is showing CFM2. You can see the eyes are nailed to the lateral canthi. Both eyes, because the lateral rectus is the only muscle which is left. The third and fourth are both affected. So, CFM can affect third primarily and also fourth. So, here you have that eyes are almost fixed in the at the lateral canthi, and this is mostly seen in Middle East countries with a lot of consanguinity. We don't see it very often here, but just to show. This is showing us atypical presentation. You have a CFM3 which can have lot of variability in presentation. Here you have this 25-year-old boy. It's a rare phenotype. You have, there is a congenital MED in the left eye. There is a typical coloboma. He has high myopia, and there is anophthalmos and this thing cystic eyeball in the right eye. So, it's and he also had cryptorchidism and typical high myopia with IR fibrosis. So, he also had systemic involvement. So, don't forget to look at them systemically, otherwise you will miss a lot of kidney issues, and these things can happen, cardiac issues. This is showing you, very often have seen MED with MGP. So, all these MED which have IR restriction and MGP are a good number of these are CFM3 because of TUB2B and TUB3 which are presenting like this. So, MED also need to be looked at as a fragmented entity. Some of these are not, MED is just a finding that eye is not able to elevate. It is not a diagnosis. The problem is that we tend to make it into a diagnosis which is not true. So, this is just that some of these could also be CCDDs. This is showing one eye Brown's and other eye superior oblique palsy. Very interesting presentation, and is also sort of albinism in this child. So, you can see that the right eye is Brown's, it is not elevating at all in adduction, and the other eye is over elevating in adduction. So, this can create, these are reported because both are CCDDs. So, you can have superior oblique in one eye and Brown's on the other eye. This is possible. So, always look out for these if you have a case like that. This is just to explain why we get into superior oblique palsy and Brown's, the same process, continuous process. We will not go into that detail. This is showing superior oblique palsy. You all know the tendons are tenuous and they could be quite or even absent tendons, and very typical presentation if it be. These are few third nerve palsies I will be showing you in brief. This was like right third nerve palsy, atypical presentations with lot of findings which are beyond third nerve. So, you can see right exo and the eye is hypo and pupil was spared, and there is not much ptosis. There is slight left right head tilt. If you look at the motility, the right eye which is largely exo, which is going beyond, it is adducting. In up gaze there is actually adduction from exo, it has gone into large ESO, and downwards it goes into a large EXO. So it is an A pattern which normally you don't see like this. An eye which was in EXO is going into extreme ESO. So this can only happen with aberrant innervation. And there is also synergistic divergence in this child as he is looking to this side. If you can pointer hai yahan pe, there is time. When he is looking to the left side, you can see the eyes are diverging and this eye is going up also. So there is a vertical divergence and also synergistic divergence. A very interesting presentation. And if you look at this, if this plays, he will show you nystagmus. See, you can see a nystagmus, which is jerk nystagmus to the right in this eye, which is normal eye otherwise. And now when you look to the other side, this eye goes into synergistic divergence and also goes up. So there is a vertical and horizontal synergistic divergence. And this eye lid droops and other eye is elevating. So a lot of dysinnervation. Okay. This is showing intorsion in this thing, sort of intorsion in right eye and extorsion in left eye. Now where do we see this? This is a conjugate torsion which you see in ocular tilt reactions. One eye intorted, other eye extorted. Otherwise it doesn't happen in most of us. So this is again a very abnormal finding, and I'll show you something more interesting. As this child looks up, you can see that the intorsion which was there in this right eye has gone into extorsion, and other eye has got into intorsion. So this change in torsion has happened because of gaze. So this is something very, this case has been present, I mean, this is published case. So very interesting. This shows that there is involvement of the autolytic pathways which are used in vestibular ocular reflex. So this is a complex thing from the vestibule, the saccule, utricle and the semicircular canals. These along the vestibular nerve, they are crossing over going to the vestibular nuclei. From there they are crossing at the level of the sixth nerve and ascending in the MLA from the opposite side. So if there is an affliction along with this pathway, you can have that kind of conjugate torsion which you are seeing here. So beyond third nerve, there was involvement of these pathways as well in this patient. That's what I want to stress. This is another child, again third nerve palsy. It will pass on no ptosis and little AHP. This picture is getting cut off a bit anyway. This is showing a video. You see this is oculomotor and trigeminal synkinesis. Now he opens his mouth and eye moves in. And see, the eye is moving sideways. In Marcus gun, what you see is that the lid is opening. Here what is happening, and see, again you have synergistic divergence here. The eye shoots down and diverges. So similar picture as compared to that. But here instead of synkinesis with the upper lid, the medial rectus and lateral rectus are synkinetic with these pterygoid muscles. So this is again rare presentation, has been published. This is another child, again third nerve palsy, and you see here is something very different a bit. She has people involving third nerve, and she will just press over upper lid and this will open. Now this will remain open for some time, about a minute, and again there will be massive lacrimation and this lid would suddenly drop. There is no improvement in the ocular motility, only the lid elevates. Now this is dropping and again she will do this. So what is happening here? The molars muscle acts as like a muscle spindle for the LPS. So what probably she is doing is that she is stimulating her molars through proprioception and she is getting this lid elevation. So important to keep in mind that molars has a very important role, and if they is aberrantly innervated, these kind of things can happen. AGPPS very brief, as some cases you will miss them if you're not careful. So the three components: horizontal gaze palsy, the scoliosis, and X-ray findings, MRI findings, which show pontine hypoplasia, the split pons, butterfly medulla, and absent facial colliculi. These are all features of brainstem hypoplasia. Of course, scoliosis and this part I am not going in detail because we are short of time. This is showing 11-year-old girl, you can see, and she is, other than scoliosis, she is scoliosis to the right, and look at the movements. No horizontal movement, vertical movements are perfect. they have convergence which is intact, and they may be confused with bilateral DRS. If you don't look at them carefully, somebody would think that this is DRS, but this is not DRS because there is no globe retraction, no other finding of DRS. Showing pupils is anisocoria and iris hypoplasia, which you can see, but these are very subtle. If you notice, Another girl with accommodative esotropia, AGPPS, she was hypermetrop of 5, but they don't respond to treatment because the eyes cannot move in vergence. So this hypermetropic accommodative hypertropia cannot be corrected by glasses. So we had to do surgery, and this is the after convergence you can see is intact in this girl. This is third one with exotropia, another girl with AGPPS and exotropia. You can see large exo and V pattern, and again intorsion in this. We will not go into this detail. This is a gentleman, as we're talking about Paul Julius Mobius, a Leipzig neurologist, also known for Mobius sign and Mobius disease, and wrote interesting monographs on physiologic weak-mindedness of women and pathology of men of genius, which were interesting monographs at this time. We will not go into the detail of Mobius syndrome. You can see here the left side Mobius with exposure and facial palsy of the left side. Is not able to close that eye. If you look on the left side image, there is good base phenomena, but total inability to close the upper part of the face is involved more. The lower part, this mouth muscles may still be spared. So that's another feature. And usually bilateral, cases can be unilateral. You may have an ESO, you may have an EXO. Facial palsy may not be very gross, and if you are not careful, you will miss it. This is showing hypoplastic tongue by Fisher, hypoplastic tongue, which may also have hypoglossal hypoplasia. The tongue could be diverting to one side because of hypoglossal nerve palsy. And here you have facial nerve palsy, which is showing that there is inability to close the eyes. This is showing arachnodactyly and clinodactyly in these cases. They can have a lot of orthopedic issues, which was known as Hanhart syndrome. So orthopedics people look at it differently as we look as differently. Duane's is another most important CCDD. You all know, you have all seen Duane's syndromes, and there is no point talking about it. More we talk, more we get into difficulties. So a very diverse presentation and very challenging. And genetics is either it is autosomal dominant. If you see a bilateral DRS, you should always think of, you should always try to do the genetic study on these children, because very often the bilateral DRS could be inherited. So you may have autosomal dominant or AR. Most simplex cases are sporadic, and the genes which are important, CHN1, SAL4, and HOXA1, which is shared by BSAS and ABDS, as I was saying sometime earlier. So this part needs to be done. I will not go into this presentation in detail, you all know. And to conclude, the concept of CCDDs is in a phase of evolution. Recent advances in imaging and genetics have advanced our understanding of CCDDs, and more have been added. Some congenital third and fourth nerve palsies, MEDs, Browns need to be classed as CCDDs because they share those features, and surgical interventions are challenging. Results modest, and multiple procedures may be required. So before doing surgery, you should be careful which ones to touch, which ones to refer, which ones not to touch, because if you touch every case, you will burn your fingers. So be careful in diagnosing, image them, do genetics if possible, and assess them, do their FPT, and only after that you should have a clear indication to do a surgical intervention. Treat amblyopia, treat refractive errors. Very important to keep in mind. Thank you so much. Any questions anybody has, we can address.
Thank you, Dr. Pandey, sir. He has elaborated the entire most complicated topic, most complicated. Even I could not understand so many things. But he has simplified and shown beautiful videos. That's why we could understand at least 50% of it. Let us hope. And let me tell you one thing. Today I have seen is that he is academically very perfect. He's just like a very super teacher. But as a SPOCI secretary, he is doing excellent job. He is arranging all the conferences very nicely, arranging all the lectures. Everything is doing it very efficiently. So hats off to him. Give him big hands.
Pandey, all with your support and cooperation and help that we are, whatever little we are trying, we are able to do. And thank you all of you for having come and attended. And I hope you learned something. And if there is anything you want to ask, we are here to clarify. We request you to become members of this POSI and participate in our conferences. It is a collective responsibility and effort by all of us, and we need to promote this specialty, because I think a lot of things have been happening which should not be happening, like amblyopia, like disturbance not being treated, and they are being going to adulthood and then ending up as almost one-eyed. So a lot of psychological issues, a lot of financial issues, and it's a very situation which is quite complicated and needs to be looked into.